Is that? All right.
All right. Great.
Speak loudly into the microphone.
I will.
Thank you.
All right. Thank you. Okay, so I'm going to talk a little about the ABCs of viral hepatitis and think about some special populations and think a little bit about why we would be talking about this at an STD update. I'm okay with questions being asked during the presentation, so if there are any, please do. The scrolling of questions up there was frightening.
Okay.
Closer.
Yeah.
Oh, there we go. I feel like I should be singing karaoke. You don't want that. No, oh my God, no. Okay, how do I advance here? Why is it not advancing? Can I use this?
Get rid of this thing here. Let that go away. There we go.
Can I use this?
You should be.
Okay, good. Here we go. So some disclosures. I do get some independent investigation funding from ViiV and Gilead. I've been a speaker for Clinical Care Options, and I write for Up to Date. Okay, so our objectives today, we're going to talk a little bit about the epidemiology of hepatitis A, B, and C. We'll talk about some of the risk factors for A, B, and C. We'll describe sort of generally who should be vaccinated and which ones we can vaccinate for, because we cannot vaccinate for all of them. We'll talk about some of the long-term consequences, and we'll just talk about how to test for each of the hepatitides. So very broadly, when we think about hepatitis, the itis means inflammation, hep means liver, and we're talking about viral. Yes, we have patients who have exposures, who drink alcohol, who come in with hepatitis, but that's really not something from a public health standpoint and STD standpoint that we can do a whole lot about in that particular setting. So we're talking about viral, so caused by a virus. And very broadly, this is a patient who, the case definition is about fever, headache. There's some GI components as well. The patient may present with jaundice, although not always. And there's laboratory data to support it. So they have elevated trans-am LFTs, and they would have appropriate serology. So I kind of think of it as like the flu plus being yellow. Okay, so here we have some yellow people. What I've got up here is I have, I don't know how well it translates, but the gentleman over on the right there is supposed to look a little bit jaundiced to you. His skin has sort of a yellowish hue. The young man in the upper corner here, you can see that the whites of his eyes are yellow. We call that scleral icterus. And then if you want to talk about where else you can see the bilirubin that's causing this yellowness, you look at the urine. So we've got normal urine over there on the right, and we've got bilirubinuria, so it looks kind of like iced tea or Coca-Cola colored. You may also have patients come in and say, my poop doesn't look brown. It looks kind of light colored. So these are kind of the symptoms that the patient may come in and say that they have, although I would tell you that, many times patients aren't going to present. They may not have jaundice, but also this doesn't hurt. It looks weird, but it doesn't hurt, and it goes away. And so we may not actually see acute hepatitis coming in to the clinic for us. So let's start off with a case. This is going to be a 27-year-old man who has sex with men. He's coming into the STD clinic, and he says, well, it kind of burns when I pee. I mean, it's really sort of hard to describe. And you're talking with him a little bit, and he says, yeah, I've got some fever. He's got a little bit of a body ache. He's not eating much, some nausea. And he tells you that he was at a party about a month ago, several anonymous partners, and on exam, you can see that he's got some swollen lymph nodes, doesn't really have a rash. So what are you thinking? What's on your differential diagnosis? Come on. HIV. Thank you, Vicki. HIV, great. What else? I'm glad we're thinking about HIV. Yeah. Viral hepatitis. Okay. And why are we thinking that? Well, we're thinking that because we're going to think about hepatitis A first. So I want to move this a little bit. I won't move that. Okay, never mind. Go back. Okay. So the life cycle of these viruses, I'm going to talk about that a little bit because I think it helps to think about how you would do the testing and how the patient's going to present and what you're going to do. So basically, hepatitis A is a non-enveloped virus. It enters the liver cell, makes copies of itself, and comes back out mostly in feces, in our bile. And the epidemiology is sort of classically the point outbreak source. So, this is I'm not going to throw any grocery stores under the bus, but this is a grocery store who has a food handler who comes in. The health department gets notified. Now it's out on the news that if you went to the deli at XYZ grocery store between February 1st and February 14th, the health department wants you to come in because you may have been exposed to hepatitis A. That's kind of what we think about classically for hepatitis A. So why do we think about it as an STD? Well, the reason is that we're nationally there have been several outbreaks across many different states, and now including close to home in North Carolina, of hepatitis A, and it seems to be focused primarily in men who have sex with men, people who are experiencing homelessness, and people who use drugs. And so it's not really this kind of classic, oh, I got it from the delicatessen. This is, these are patients who are having ongoing risk factors and exposure, and so it's a little bit more of a kind of a continuous source outbreak. And what's different about the hepatitis A that we've been seeing across the country, is that, first of all, we have a 70% hospitalization rate of this particular hepatitis. In general, most viral hepatitis A outbreaks, the hospitalization rate is around 46%, and the mortality is around 0.4%. These hepatitis A outbreaks are associated with 70% hospitalization rate and a 3% mortality rate. UNC, I can tell you, we've had a death from hepatitis A. We've had a liver transplant from hepatitis A. So it's not just, oh, it makes you yellow and you have a bad stomach upset and you can't work in the food handling industry. This is now something that we need to think about in our STD patients. And here's our epidemiology. Do I have a pointer? Yes, I do. So this is North Carolina's epidemiology. Doesn't seem to transmit. Okay, so essentially this is the average number of hepatitis A cases, acute hepatitis A cases in North Carolina from 2013 to 2017 was about 42. Okay, last year we had 100. Okay, so we've had a couple of outbreaks. One focused in Charlotte. We've been seeing some increasing number of cases in Johnston County, so it's starting to kind of pop up sort of all over North Carolina. So it is something to think about. And I'm going to talk about why I'm saying just vaccinate, because you should just vaccinate. So who needs to be vaccinated for hepatitis A? Here's the list. You can read it, and I know that these slides are available. In short, just vaccinate people. Okay, I'm not trying to be pithy, but if you have somebody who comes into the STD clinic, so first of all, does North Carolina require hepatitis A vaccination for our kids? No, it does not. And so if you have a young man who's coming in and is going to talk about PrEP, who has some HIV risk factors, he should be vaccinated. Okay, yes, you can check the serology. That's great if you want to do that. But many of us know that in the STD clinic it's kind of catch and release. This is an opportunity for you to vaccinate. And one vaccination gives what kind of protection? A lot or a little? A lot, for at least 10 to 15 years, okay, in the realm of 90% protection for 10 to 15 years. You give that second vaccination in about 6 months, that's great. Now you've got at least minimum 25 years of protection. But this is a great opportunity to vaccinate. So this young patient who came in, he's got fever, he's got the swollen lymph nodes. Yes, we're going to check for acute HIV. We're going to talk about PrEP, but we're also going to vaccinate him for hepatitis A, assuming he doesn't actually have it at the time we're seeing him. So the testing, actually, I don't think I talked about the testing for hepatitis A. So how do we test for hepatitis A? Blood work, right? So acute hepatitis A, you would order a hepatitis A IgM. That is, IgM is kind of the acute immune globulin. It tells us when the patient has recently been infected. And so, if we had opportunity to test that young man, which we would through the state lab, and his acute IgM came back positive, then we're going to be talking about a public health investigation and talking to him about his sex partners. But if it came back and it was negative, he'll be somebody that you would want to think about vaccinating. So the infection control, this is killed by heating for at least 1 minute to over 185 degrees, and you can disinfect with bleach and water. Any questions about hepatitis A? For a while with what? It's pretty hardy, and it can live for days. So it's fairly hardy. The other thing that you would do is, let's say that let's say that this young man, you tested him and he has acute Hep A. Okay, what are going to be the public health steps after that? All right, we're going to reach out to his contacts. We're going to try and see if we can get anybody who was at that party, and we want to bring them in. And we're going to do what for them? Vaccinate, right, good. All right, good. And when will we use immune globulin? If somebody was allergic to any of the vaccine components, for a child less than 6 months, right? So if he had actually been vaccinated, say he traveled as a student, if you had documentation of that serology, of that proof, I don't think I would revaccinate. No. Okay. Let me go back. All right. So case number 2. This is going to be a patient. This is a 23-year-old female. I've actually had a patient very similar to this. She comes into the STD clinic and she says that she has a rash. Okay. We see lots of rashes in the STD clinic. It started about 3 days ago. It's red, hot. Her elbow's kind of tender. That's what she really wants you to look at. But you also notice on her hands that she's got some little kind of funny-looking lesions there, some little kind of dried sort of eschars. She admits to being a woman who has sex with men. She's had 4 lifetime partners. She has experimented with injection drug use. And that's the way I like to ask that question. I don't say, do you use IV drugs? It's kind of a, have you ever experimented with IV drugs even one time? Because that sort of is less pejorative, I find, when I talk to my patients. But as an aside. So she has experimented with injection drugs. So what is on your differential here? So syphilis, thank you. Cellulitis, right? Okay. We can see a rash with acute HIV. She has admitted to injection drug use, so it would be something to think about, but she's a little bit less classic. Okay. Anything else that you want to think about testing with her? We don't know if she's pregnant. Yeah, okay. All right, so this is meant to be talking about hepatitis B, all right? And hepatitis B has a global distribution. It's really highest in sub-Saharan Africa and East Asia, where about 5 to 10% of the population is chronically infected. It's responsible for 750,000 people dying annually. In the U.S., our prevalence is around 0.4%. We are seeing an increase in acute hepatitis B in our younger population, mostly related to injection drug use and people who use drugs. The vaccine for hepatitis B became available in 1981, and it was required in North Carolina starting July 1st, 1994. So most of our young population has been vaccinated, but we are still seeing some acute hepatitis B, most likely related potentially to waning immunity, and then maybe some folks who just escaped vaccination. Looking at North Carolina's epidemiology, so again, this is the average number of cases between 2013 and 2017. So for Hep B, average is around 149. We have seen an increase with 195 in 2017 and around 200 this past year. So it is on the rise, and it is important to be looking for it. All right, so I guess the next question is, what test would you order? We're all comfortable with ordering hepatitis B tests and interpreting them, and everybody's good. I don't need to cover this at all. Okay, great. Okay. We're going to talk a little bit about that next, because I don't want anybody to feel like they're a deer in the headlights. Okay, so the hepatitis B life cycle. So again, the virus enters the cell, it uncoats. This is a DNA virus, so some of the DNA goes to the nucleus. It starts making copies of itself. It starts making the stuff that it needs to continue its life, because that's all it really wants to do. So we've got the surface antigens, and then we've got the envelope antigen that's being produced, and you can never really, you cannot detect the core of the hepatitis B virus, but you can detect IgM, the antibody to it. Okay, so kind of thinking about that, when you're thinking about how do I diagnose this person who's looking at me and saying, do I have hepatitis B, so the average incubation is about 8 weeks, but it can be 4 to 26 weeks from the time of exposure to developing symptoms. The early stuff is what you're going to see. That's the stuff of the virus, the surface antigen, the envelope antigen. You can actually measure the DNA. You can't measure the core of the virus, but you can measure the DNA. And then the antibody response comes later. So, like I said, incubation is on average average is 8 weeks, but 2 to 3 months is kind of what I tend to think of. And this is transmitted very similar to HIV. Okay, it's exposure to infected body fluids, so blood, primarily semen, and the symptoms will resolve over about a 3 to 4 month period. The nice thing about hepatitis B, if there is a nice thing, is that most of the time it's self-limit. 90% of patients will actually clear this on their own. Okay, but there will be a percentage that doesn't. So let's think about our young lady again. Let's say that she's pregnant, and you get your labs back, and her Hep B surface antigen is positive. Oh, holy crap! Now what? What are we going to do? Okay, we want to find out her partners. Okay, we want to test them and vaccinate them. Great. What else do we want to do? Right. And what are we going to do when she delivers? H-big, and then, yes, and start the vaccine series in the babies. Within what period of time? Quick as possible, 12 hours, right? Do we ever treat hepatitis B during pregnancy? Sometimes, yes. Okay, so that's the way I asked that. It's a good test-taking skill. Do we ever? Basically, if the viral load of the hepatitis B virus is over 200,000 or she has elevated LFTs, that would be a situation where you would think about treating the hepatitis B. Okay. Okay, for the people who don't clear hepatitis B, in addition, if we're talking about women who could be of childbearing age, we want to know about that. There is a risk of a lifetime risk of developing liver cancer. And then this is just kind of a sort of quick and dirty look at how to look at the tests or the serologies and interpret. Again, surface antigen indicates infection. Okay, if it's there and if you kind of look through it, it's either acute, it's chronic, or it could be somebody who's a healthy carrier or a precore mutant. All right, envelope antigen, that indicates infectivity. Okay, and when you're thinking about and you're treating a patient who has hepatitis B, it'd be nice to see this envelope antigen flip over to envelope antibody that indicates that you have treated and you're controlling the infection. Many patients, especially older patients, won't actually get there. This is acute infection because we're talking about IgM. Okay, and then the hepatitis B DNA can actually be measured, much like with HIV. Antibody to hepatitis B surface antigen indicates protection, immunity, and then that indicates acute, recovery from acute infection or treatment. Okay, so this is a really long list of who should be vaccinated. It's very, very tiny print. You all can look at this after the fact and look it up, but certainly things to think about. So patients who are coming into the STD clinic who are seeking treatment for an STD, think about, have you been vaccinated for hepatitis B and should you be vaccinated? Men who have sex with men, persons who are using drugs, certainly any of my HIV positive patients need to be tested for and vaccinated for hepatitis B if they don't have immunity. The other important thing to think about is chronic hepatitis or chronic liver disease. So backing up a little bit to our hepatitis A patients who are getting very sick from the hepatitis A infection, getting hospitalized and dying, many of those patients actually have other underlying liver diseases, so they're either chronically Hep B or they're cirrhotic or Hep C. So anybody who has chronic liver disease should be vaccinated against hepatitis B. Okay, unvaccinated adults, vaccines are good. Okay, so perinatal Hep B, we covered this a little bit. The reality is if we don't give post-exposure prophylaxis to our infants, about 40% are going to develop hepatitis B, and then about 25% of those are going to go on to develop and die from chronic liver disease. So really important, if we have a mom in front of us and we don't know her hepatitis B status, we need to know that. And so there's actually, it's required that we do testing for screening for hepatitis B among our pregnant women, unless you know her to be positive. Any questions about that? Yes? Can I go back to that? This is about healthcare workers. Yes. So if you've had a series, getting back immune, and then getting older, it wanes. Yeah. So there's actually guidelines from the CDC about that, about what to do for healthcare workers. And if you have evidence that your immunity has waned, there's actually a suggestion for a booster. And then I believe if it's still no response after that, I think you're done. I have to go back and look. I have to check that every time because I don't have it compromised. But yeah, so it does happen. As we get older, that immunity can wane. Yeah. Good question. Thank you. Any other questions? Okay, so the thing about hepatitis B, it's great that most people clear it. The ones who don't, this is not curable. This is a lot like HIV, so I kind of think of it along those lines. And the treatment, it's complicated. There are guidelines. It's about looking at LFTs and how much of the virus they have and other underlying immune problems. Whole set of guidelines that it would be more than we could actually cover here. The nice thing, the thing about hepatitis B for my patients who are HIV infected, the bulk of my patients who are HIV and Hep B co-infected, when I treat their HIV, I'm also going to treat their hepatitis B just by virtue of the medications that we have and that are used for treating HIV. Again, remember, you want to vaccinate this patient for hepatitis A. You want to check for hepatitis C, which I didn't hear, and HIV. Any questions? Everybody still awake? Okay. Everybody out in TV land still awake? Okay, we're going to talk about case 2 again a little bit. So yes, we talked about hepatitis B. You got her serologies back. She was vaccinated as a kid. Her surface antibody is positive, surface antigen is negative. She is not acutely infected. Okay, what about hepatitis C? She is somebody who is admits to using some injection drugs. Okay, so the way this is what we have for testing for hepatitis C. So first of all, there is no commercially available acute hepatitis C. Well, there's no commercially available IgM test for hepatitis C. So this is about antibody and RNA. Okay, so most people, and at the state lab we do this as well, most people, if the antibody is positive, there's a reflex to the RNA. And the reason for that is that indicates active infection. So just kind of a quick and dirty little slide here. So antibody positive, RNA positive, that person is currently infected, could be acute. Antibody positive, RNA negative, either old infection or very, most likely old infection and cleared or treated. You can have patients who are antibody negative and RNA positive. And the reason for that is, again, we don't really have an IgM test. This is IgG, which takes several weeks to develop past the time of exposure and infection. And then somebody who is antibody and RNA negative is most likely susceptible and never been infected. Okay. So for hepatitis C, the incubation is 3 to 4 months on average. This is about exposure primarily to infected blood. So I think about it in my patients who admit to any sort of drug use or injection drug use. So it doesn't have to be needles. It could be somebody who shares a straw for snorting cocaine. It could be somebody who gets a burn on their lip from a crack pipe. It can be transmitted sexually. It's a little bit more difficult with heterosexual sex, but it can happen. And the reality is that the bulk of patients who develop acute hepatitis C go on to have chronic hepatitis C. Okay? If it's going to clear, most patients, about 90%, will clear in the first 6 months following their exposure. So when I'm seeing a patient in the clinic who has hepatitis C and I'm talking to them about, do I want to treat them? If it's somebody who is, actively has been actively injecting drugs, I kind of start the clock for when they were infected at their last injection. So if they injected last December 1st, I'm going to follow them until we get to about June 1st, because most patients, if they're going to clear it, they're going to clear it within that first 6 months. If that patient doesn't, then I'm going to start thinking about, okay, maybe we need to think about treating you. Let's see, and I'm going to show you some more slides a little bit later about cirrhosis. But for patients who do not clear it, lifetime risk of cirrhosis and liver cancer over the next 20 to 30 to 40 years is elevated. I have a little note here about hepatitis C viral loads being higher than HIV, but lower than HBV. So if you kind of rank them, hepatitis B viral loads are in the tens of millions. Hep C's are in the millions, and HIV are in the hundreds of thousands. Okay. So North Carolina's epidemiology, national rate of acute Hep C is about 0.7 per 100,000 population. In North Carolina, we've calculated to be about 1.1. In 2017, we had 186 cases of acute Hep C. Again, how is this patient, how are we diagnosing acute Hep C? Patient has to come in, right? And many of our patients who maybe are injecting drugs are not going to come in. They don't want to come in and see us and talk about injection drug use. First, it's illegal. Second, it's very stigmatizing. So, and it doesn't hurt. You know, oh, you look a little yellow, it doesn't hurt, starts to clear up, must have been nothing, okay? Or maybe it was something and, you know, they're just not going to address the issue there. So the reality is that for every case of acute Hep C, this is an estimate that was done in Maine, there are probably about 15 more cases out there of acute Hep C. So this is really a problem that we're trying to wrap our arms around. And in North Carolina, for patients who, again, you know, we have 186 acute Hep Cs. Many of those will go on to develop chronic. And in 2017, we had about 21,000 cases of chronic Hep C that were reported. So sort of our epidemiology here as well. So over kind of in the western part of the state, you know, this heat map demonstrates the orange counties are cases where the rates are exceeding 19 per 100,000 population. And then we have kind of the acute and the chronic Hep C. And what you can kind of see here is we have sort of a bimodal distribution, we have a distribution of more Hep C in younger, acute Hep C in younger patients, and then our chronic Hep C being in our older patients. And again, part of this is because of reporting issues. Let's see. Talking about the second epidemic. So I've talked to you about the acute Hep C, 186 cases or so. You know, we estimate that in North Carolina that of our patients with chronic Hep C, it's about 110,000. Okay. What that means is 110,000 patients who are at risk of liver cancer, of cirrhosis, and these are patients who should be screened. The CDC recommendation is that anybody born between 1945 and 65 be screened at least once for hepatitis C and be considered for treatment. You know, anyone who's ever injected drugs even once should be screened. Persons who received any sort of blood product before 1992. Anyone who's on hemodialysis or ever been on hemodialysis, certainly my HIV positive patients should be screened for hepatitis C. And if you have a patient who comes in and, you know, has elevated LFTs or signs and symptoms of liver disease, they should be screened as well. So, any questions so far? Okay, so this is kind of the long-term and rates of infection for hepatitis C. So you have the patients who are acutely infected. You have the 70% who develop chronic infection, and if you kind of march on down through it, see that the risk of cirrhosis is about 10 to 20% over 20 years, and then for liver cancer is about 1 to 4% per year. And I have some cost estimates there, maybe. All right. And so we have some cost estimates here in terms of what it costs for a liver transplant and in terms of costs for liver cancer.
Technology's great as long as batteries are working. There you go, this one's fully charged. I'll get it. Mm-hmm.
It's really awkward to watch up here, isn't it? Okay. All right, so perinatal hepatitis C. So this was our 23-year-old lady. She is of childbearing age, and you know, we are seeing pregnant women coming in and being diagnosed with Hep C. So it's really important to keep in mind that women who are infected with Hep C, who become pregnant and deliver babies with Hep C, there is a risk of transmission mother to child. It is most likely, for the most part, it's happening in the peripartum period of time with that exposure to infected blood. And there's about a 5% transmission rate. There are some things that increase that transmission rate. So women who are HIV positive, that transmission rate increases. Women who are currently actively still using injection drugs or using drugs, that can increase the rate. Sort of any procedure that exposes the baby to mom's blood increases the infection risk. There doesn't seem to be a lot of correlation between what the viral load for the hepatitis C virus is. Does not look to be associated with breastfeeding, assuming that mom's nipples are not cracked and bleeding. And we really don't recommend, it's not that we suggest that a C-section is advised based solely on hepatitis C. In terms of diagnosis for the baby, so it is Generally speaking, because mom's antibodies are present, we don't recommend antibody testing for the first 18 months of life. You can test after that, but you can do RNA testing. So if the baby comes in and you want to know within 2 months of birth, you can do RNA testing on the baby. Okay, here we go, what I just said. Let's talk about treatment. So what are the recommendations for treatment? So certainly patients who are chronically Hep C, there's a lot of work going on to try and get those patients into care and treated. We really don't have a vaccine for this, so treatment is well, I shouldn't say treatment is prevention because that thinks of HIV, but if we can clear hepatitis C in a population, microelimination, the thought is that would reduce risk of transmission. For patients who are acutely infected with Hep C, like I said, in clinic, I will follow them, and if they do not clear, then we start talking about treatment. What about my pregnant patients? Can I treat them? It's really not recommended. So if I have a young woman who comes in who's of childbearing age, I suggest to her that we really need to be on some form of birth control while we get you through the treatment. Then after that, there is a registry, so for women who have gotten pregnant while taking the Hep C drugs, and it does not, there's been no report of any adverse birth outcomes from that, but it's still just not recommended at this point. We talked a little bit about the hepatitis A infection control, didn't talk about B and C. Again, this can live outside the body for anywhere from 7 days for Hep B and up to 4 days for Hep C. And generally speaking, the disinfection, 1 to 10 dilution of bleach is kind of what I suggest to my patients. Certainly not sharing anything at home that could be contaminated with infected blood. So no nail clippers, nail scissors, toothbrushes, razors, anything that could be contaminated with infected blood shouldn't be shared. And then I just kind of wanted to just hit again sort of what are the things to think about in terms of the risk factors and kind of the incubation. So again, Hep A, this is kind of fecal oral. So, when you're thinking about a patient who, is engaging in some sex practices that may result in, fecal oral contact, think about hepatitis A. It's about a 1-month incubation. The classic story is the food handler, but keep in mind we are having some continuous source outbreaks, and that's again in our men who have sex with men, persons who use drugs, and persons experiencing homelessness. This is preventable. Vaccinate. Hepatitis B, spread primarily through infected blood, 3 to 4 month incubation. This is, injection drug use, mother to child, dialysis units. This is also vaccine preventable. Hepatitis C, blood and body fluids, incubation is on the 2 to 3 month incubation. Again, infected body fluids, no vaccine, but this is treatable. Okay. Now what? Okay. Any questions while we wait for? Yes.
Can you talk about your thoughts of treating hepatitis C in folks who are actively injecting drugs?
Yeah. Do we dare?
Yeah, I changed the batteries.
Okay.
Turn this off for me.
Cool. All right. Oh, good. So the question that Dr. Mobley had was my thoughts on treating patients for hepatitis C who are actively using. And I think that it is an opportunity to treat more than one thing. There are clinics that are doing medically assisted therapy for drug use in addition to treating the hepatitis C. Now, a patient who is, actively injecting, this is, when you're seeing the patient and evaluating them for Hep C treatment, it's an opportunity to talk about, clean needles, to talk about Narcan to prevent overdose. It's an opportunity to vaccinate for hepatitis A and B. It's an opportunity to talk about HIV and even talk about PrEP for that patient and test for HIV. And so kind of as I'm lining them up to get them treated, there are multiple opportunities for me to see the patient and make some interventions. I think it's important to have, a committed behavioral health specialist also working with you for that patient to ensure that they are going to be stable enough to take these medications, because we are talking about a commitment of 8 to 12 weeks of medication, but it's really a great opportunity. And many of the times, these patients, this is actually kind of the impetus to make a change and to commit to reducing or quitting drugs and also getting their Hep C treated. So I think it's an opportunity, and I know that Medicaid has their readiness to treat, and one of the questions is about their sobriety and drug use. I do think, though, that having a patient in front of you who is committed and is there, who made it to that appointment despite some ongoing issues in their life, that's somebody who you have an opportunity to say, we can treat more than just the Hep C here. Do I just pick one?
Yeah,
Okay.
there's one in.
Really overwhelming.
I'll pause it for you.
Okay, so is there currently work on a vaccination for Hep C? I suspect that there may be. I'm not as familiar with the kind of the research on that. We do have the really effective treatments, so I'm not sure what the level of what's going on with that. Okay, are restaurants and other food handlers routinely tested for Hep B? Is this a requirement? I am going to have to. And it is not. So no, and it is not. Okay, where can persons get treatment for chronic Hep B? So if this is a patient who, like I said, if they're HIV infected, they're in care, this is an opportunity to treat their hepatitis B. If they are an infected healthcare worker, in all likelihood, they are also somebody who's going to be able to access treatment. Chronic Hep B treatment, I think, is still evolving. I think that it is available through gastroenterology and through ID. One of the issues is getting access to the medications. The diagnosis on the rash, that was cellulitis and skin popping. How do you treat chronic Hep B? So there are 3 medications that are available for treating chronic hepatitis B. Actually, I should say 4. There's tenofovir alafenamide, tenofovir difumarate, there's lamivudine, and entecavir. So these are medications that are available. How did you just click? No. Where do we refer for Hep C? So that's actually, I love that question. So in the viral hepatitis group at the state, we have been working with Duke and with UNC to train primary care providers who are caring for under and uninsured patients through FQHCs and through health departments. We do actually have a list of who those providers are. We've actually managed to reach providers from basically the western part of North Carolina to the east. We've trained almost 100 providers. So there's likely to be some access locally to a primary care provider, and that is also ongoing. So, we are recruiting primary care providers who have an interest and want to take this on. There is a way to get the medications without paying for it. Actually, to be honest, patients who are uninsured are so much easier to take care of, aside from the labs, because the access to the medications is much easier, but it is available. And it's fairly straightforward, and we're talking about cure rates in the 96 to 99% rate, after 8 to 12 weeks of treatment. Okay, screening guidelines. When are screening guidelines going to include people who use drugs, period? Yes. So hepatitis A is a sexually transmitted disease. This is about it's about getting poop in one's mouth. Okay, so depending on what the sexual practices of your patients are, if there is some analingus going on, so mouth to anus, and you have an infected person, that is how it gets transmitted. Okay, there's a vernacular for it we can talk about offline. But it's really, it's about that, getting feces, getting poop that is infected into the one's mouth. Okay. Any other questions? Several. Oh, I have 5 minutes left. Okay. Let's see, how do I pause? Okay, if someone has a positive Hep C antibody and the RNA then clears without treatment, do you need to recheck? So when you're considering somebody has acute hepatitis C, again, I said I follow them for about 6 months. I will get an RNA basically every 2 months during that time period because there can be some fluctuation. If they are negative at 6 months, I don't need to recheck them unless they come back in. So if they are continuing with injection drug use or continuing with risk exposures, then yes, they should be screened somewhat more regularly. Generally speaking, I would say every 6 to 12 months, and then depending on what's going on with their LFTs. Where's the monitoring question? Right, yes. So if they, I think I just tried to answer that one. So if somebody clears RNA without treatment, what you would do is if they have ongoing risk factors, rescreen them every 6 to 12 months, depending on what what's going on with those ongoing risk factors. Certainly if they come in and they have some elevated LFTs or they look like they're acutely infected. So you cannot, this hepatitis C, you don't develop immunity. So it is possible to get reinfected. So if somebody is, that's what the question was. If somebody is infected and they cleared on their own, there is the chance of reinfection. Again, also if a patient, when I see a patient and I'm treating them for hepatitis C and they finish their treatment and, yay, you're cured, we have a discussion about, okay, the risk factors, the things that you were doing that got you infected in the first place, if those are still ongoing, you are at risk of reinfection. You do not become immune to this disease. And where's the resources question? Okay, so the resources for hepatitis C management, again, if you go to ncpublichealth.com and come to the hepatitis branch, we do have some resources there in terms of where you can find a CHAMP provider. The hcvguidelines.org are also an excellent resource in terms of testing, in terms of thinking through the treatment. Another one that I like to bookmark and have on my laptop is Liverpool Interactions. You probably need to just Google that and definitely say like Liverpool Hep C because otherwise you'll get the soccer team. Liverpool Hep C and then bookmark it because there are some drug interactions with these medications, and that's actually a really handy guideline to use when I'm thinking about, okay, I'm going to treat the patient, look at what the interactions might be. Where do we refer hepatitis Hep C? So again, contact us and we can tell you who might be a CHAMP provider in your community. If you have a primary care provider who has gone through the CHAMP program, they will do an excellent job. Many IDs are starting to treat Hep C, and then your gastroenterologists.
Any additional questions from the in-room audience? You mentioned earlier that sexual partners of those that get through some of previous years of life. So it's minimal risk.
Yeah. So right. So for hepatitis C, the sexual transmission risk among heterosexual couples is very, very low, like very close, approaching zero. For my men who have sex with men, there is a higher rate of transmission that way. And then for my HIV positive men who have sex with men, it seems to even be higher. So it does kind of depend on what the risk factor is.
Thank you, Dr. Swygard. So we're getting close to the break, so hang in there. Our next speaker is Andrea Lewis. She's going to talk to us about some of the resources that are available out there for your work that you do in STD prevention and HIV prevention. And she is our new North Carolina Prevention Trainer Coordinator.
So hi everyone, as Dr. McNeil said, my name is Andrea. Some of you may seen my name pop up recently on emails from Dr. Mobley, since I am the new local program coordinator for the Alabama North Carolina Prevention Training Center. So I'm the new person that will be completing the exam checkoffs for the new APPs who are coming into the health department. I've already received some emails from some of you guys, and I'm excited to be working with you all. So I am here today to give you guys some general and quick information on what the PTC is and does. So the Alabama North Carolina Prevention Training Center is one of 8 regional centers of the National Network of STD Clinical Prevention Training Centers. We are funded by the CDC to assist healthcare providers and organizations with the skills, knowledge, and experience that they need to address and prevent STDs. So in conjunction with our Alabama partners, we do offer free online STD and HIV continuing education credits. So you can kind of go to this website here and earn free CMEs and CNEs. And these are some examples of the modules and content that we have on the website. And we all are free, so this is a great resource. And this is kind of what the website looks at, and then kind of goes into a little bit more detail about the modules that we do have on site. Additionally, the NNPTC does offer online consultation services to all healthcare providers across the U.S. So if you have a tough question or you want to get a second opinion, please reach out to this website so that we can help you. This website also offers free CME credits, so you can definitely go there. And then for any HIV or AIDS education and training, there is the North Carolina ATEC, so the AIDS Training and Education Center, and they also offer a wide range of training opportunities for healthcare professionals, including lectures, webinars, and conferences. So these are just definitely some great resources for you guys for any HIV, AIDS, or STD trainings that you guys may need.
Thank you. We have a brief break right now, and we'll be back at 11 o'clock. So we'll see you soon when we'll be hearing about field services.